Welcome to the Deep Dive, the place where we take complex, essential knowledge and distill it into immediately useful insights.
Today, we are really undertaking a deep exploration into the very foundation of clinical diagnosis.
And we're focusing on one of the most systematic and, frankly, anatomically intricate areas of the body, the thyroid gland.
We're going to examine how a master clinician approaches a neck swelling, moving step by step from conversation to confirmation.
And our guide for this is, well, it's an incredible piece of work.
It is. This deep dive is built entirely upon a systematic pathway, showcasing the enduring power of fundamental physical diagnosis. Our source material is drawn from key excerpts from Chapter 27, Examination of the Thyroid Gland, taken from the authoritative text Clinical Surgery by S. Dace.
And crucially, the clinical rigor within this material, it reflects the specialized insights contributed by Dr. Senthil Kumaran, an associate professor of surgery at AIIMS Nagpur, India.
Right, so this isn't just theory. This is a comprehensive, structured approach that dictates precise actions.
And that's our mission for you, the learner, today, isn't it? To distill these key systematic steps.
Absolutely. We're talking history, inspection, palpation, percussion, and auscultation. We want to break down these steps to demonstrate how the physical exam acts as the initial, indispensable filter.
It's what lets a clinician rapidly differentiate, say, a relatively harmless colloid goiter from a life-threatening aggressive anaplastic carcinoma.
Often long before advanced imaging has even been ordered.
Okay, so let's unpack this clinical mastery, starting with the crucial first step. If the eyes are the window to the soul, the detailed history is, I suppose, the window to the disease process.
It really is. The initial history is perhaps the most powerful diagnostic tool available.
Why is that?
Well,
Because you're getting the patient's story.
Yes, but it's more than that. The patient's context, their demographics, their geography, their daily life, it immediately begins to narrow the diagnostic field significantly. We have to start with age and sex.
The source material is fantastic here because it offers such a specific age-related probabilities that guide your very first hunch.
It really does. So think about the patient's age profile in relation to the most common causes. For instance, a simple goiter, often related to endemic iodine deficiency or sometimes something called dysharmogenesis.
Which is a defect in the hormone synthesis pathway, right?
Exactly. That kind of goiter is overwhelmingly common in young girls as they approach puberty. The metabolic demands of adolescence can just trigger the enlargement.
And that contrasts so sharply with what you see in the next phase of life.
Precisely. If we see multinodular goiters, or the generally benign colloid goiters, these tend to emerge in women in their 20s and 30s.
So the gland itself has changed.
Right. Often due to years of intermittent stimulation and involution. It's a different pathology.
I really appreciate the caution the source gives regarding malignancy. We often think of cancer as a disease of the elderly.
And that's a dangerous assumption here.
So the age helps profile the type of malignancy, which is a vital distinction.
That's a critical word of caution. While it is true that anaplastic carcinoma, the most aggressive and highly lethal form, is almost exclusively a disease of old age, that is the exception, not the rule.
Okay.
Papillary carcinoma, which is often slow-growing and has a much better prognosis, is commonly seen in young girls and adolescents. Follicular carcinoma tends to affect middle-aged women.
So age is less about if it's cancer and more about what kind of cancer it's likely to be.
Exactly. It's about the pathological type.
And the staggering gender disparity, we can't overstate this. Thyroid diseases seem to have a strong preference for the female sex.
It is a profound disparity. I mean, across all thyroid pathology, simple goiters are much more common in females. But when we look at autoimmune and functional disorders, the ratio is dramatic.
How dramatic?
Thyrotoxicosis, for example, is 8 times more common in females. Even thyroid carcinomas maintain this skew with a 3-to-1 female-to-male ratio.
Wow.
And it helps you differentiate further. If you are seeing a young patient with primary toxic goiter or Graves' disease, they are generally young. Conversely, patients presenting with Hashimoto's disease, the autoimmune thyroiditis that often leads to hypothyroidism, are typically middle-aged women.
So that initial profile is, as the source says, non-negotiable.
Absolutely.
Okay, let's pivot from biology to psychology specifically. The link between worry, stress, and psychic condition. The source material suggests a powerful connection to primary thyrotoxicosis. But what's the nuance here? Does stress cause Graves' disease?
That's the crucial distinction the clinician has to grasp, and it's why the history taking has to be sophisticated. Stress and strain do not cause primary thyrotoxicosis. It's an autoimmune condition.
Okay.
However, stress may act as a potent trigger in susceptible individuals. The patient presenting with primary thyrotoxicosis often exhibits an unbalanced psychic condition, and the accompanying worry, tension, nervousness, and anxiety are often described as the embarrassing features of the disease state.
So you need to ask about that specifically.
You have to. You have to ask about recent high-stress life events or chronic anxiety to establish this connection.
So it's a feedback loop. The disease causes anxiety, and high stress might have kicked off the symptoms in the first place.
Exactly. It's a vicious cycle that confirms the neurological component of the disease.
Next, let's explore residence and goitrogenic factors. This is the classic iodine link that defines endemic goiter.
This is fundamental. If the patient grew up or currently lives in an endemic region, iodine deficiency is the #1 suspect.
And these regions are very well defined, aren't they?
They are. Endemic goiter has a peculiar geographical distribution corresponding precisely to areas where the soil and water are deficient in iodine. The source clearly identifies these goiter belts: the Himalayas, the Vindhyas and Satpura ranges in India,
Right.
the Mendips and Derbyshire in Great Britain, and the Great Lakes region in North America.
That immediately simplifies the differential diagnosis, but it's not just about iodine deficiency, is it? There are factors that actively interfere with iodine uptake.
That's where the historical probe has to get really specific about goitrogens.
Like what?
For example, calcium is specifically noted as goitrogenic, especially in areas that produce chalk or limestone, like Southern Ireland. And the dietary history is essential. You have to ask about the intake of large amounts of vegetables from the brassica family cabbage, kale, rape.
Because they contain thiocyanate,
Right.
which interfere with iodine utilization. Conversely, a low intake of iodine-rich sea fish is also a key historical clue pointing toward dietary risk. So the clinician has to probe dietary and residential habits thoroughly.
No question.
Now, let's move to the swelling characteristics, pain, and pressure effects. The patient's description of the mass itself. Onset and growth rate seem vital for separating benign from malignant.
They are absolutely vital for prognosis. We need details on onset, duration, and the rate of growth. A slow-growing, long-duration swelling is reassuring.
It suggests what? A simple goiter?
A simple goiter, a colloid nodule, or perhaps a very slow-growing carcinoma like papillary or follicular. However, a rapid rate of growth is highly concerning. And that points either to a high-grade malignancy like anaplastic carcinoma, or, less ominously, an acute internal hemorrhage into a pre-existing cyst or nodule.
And pain. If a goiter is typically painless, what does the presence of pain tell us?
Pain immediately redirects your focus. A simple goiter is painless. So pain suggests either an acute inflammatory process like a thyroiditis, or advanced malignant disease where the tumor is rapidly infiltrating surrounding nerve structures and capsules.
What about Hashimoto's?
Hashimoto's often causes persistent discomfort or a feeling of pressure in the neck, but sharp pain is usually infectious or malignant.
There's a fascinating question listed in the source that relates back to our discussion of the nervous system, asking, how does the patient sleep at night?
Yes, or does she spend sleepless nights?
It's a beautiful example of using subtle historical clues to establish systemic involvement.
It is, because sleeplessness, stress, and strain are classic manifestations of the nervous excitement associated with primary thyrotoxicosis. If the patient is suffering from insomnia linked to anxiety and palpitations, that is a strong indicator of a hypermetabolic state impacting the central nervous system.
And finally, the life-threatening pressure effects. What are the 3 cardinal structures whose compression we have to rule out?
The trachea, the esophagus, and the recurrent laryngeal nerve.
Okay.
So we have to specifically ask about dyspnoea, difficulty breathing indicating tracheal pressure, dysphagia, difficulty swallowing, though the muscular esophagus is rarely completely obstructed, and hoarseness of voice.
And hoarseness is particularly sinister.
Extremely, because it suggests recurrent laryngeal nerve paralysis, a classic sign of infiltrating late-stage carcinoma, most often anaplastic.
And the most worrying physical presentation.
Stridor, that harsh whistling sound produced when air rushes through a significantly narrowed trachea. That mandates urgent investigation.
We must also probe for symptoms of myxedema, hypothyroidism, which provides such a stark contrast to the hyperthyroid state.
It's the mirror image. The symptoms of myxedema are the exact opposite of thyrotoxicosis.
So instead of weight loss,
There is weight gain, despite a poor appetite. Instead of heat intolerance, there is distinct preference for warm climates and intolerance to cold. The skin is dry and inelastic, and the face is typically puffy.
I recall the source mentioning a very specific physical finding related to the eyebrows.
Yes, the characteristic loss of the outer two-thirds of the eyebrows, known as the sign of Hertoki. It's a classic, though not universal clue.
And other symptoms.
Muscle fatigue, profound lethargy, chronic constipation, and a mild hoarseness due to vocal cord edema.
Wrapping up the history, what key elements of past family history are we looking for?
Past history has to include any previous treatment, surgical or medicinal, for a neck swelling.
You have to ask about drugs too.
Absolutely. We have to specifically ask about drug intake, as certain medications like paramindosalicylic acid, PAS, sulfonylurea, and antithyroid drugs are known to be goitrogenic. And if we suspect a thyroglossal fistula, a history of a previous abscess is relevant.
And family history.
Equally important, goiters, enzyme deficiencies, primary thyrotoxicosis, and thyroid cancers all demonstrate familial tendencies. A diagnosis in a relative significantly increases your suspicion.
The moment the patient walks in, the general survey begins. This offers immediate, non-invasive validation of the hormonal status you just established in the history.
This is where we read the body's clues.
The key is observing the patient's build and state of nutrition, the metabolic contrast in action. This distinction is immediately visible.
It is. In thyrotoxicosis, the patient is catabolic. They're typically thin, underweight, often exhibiting muscle wasting, and frequently complaining of excessive sweating.
Their system is running too hot.
Exactly. Conversely, the hypothyroid patient is anabolic and retaining fluid. They're usually obese and overweight, appearing heavy or sluggish.
And if it's cancer?
If the underlying disease is advanced carcinoma, we might observe signs of anemia and cachexia, which is that severe, profound wasting of muscle and fat you see in chronic debilitating illness.
The facies and mental state also provide these dramatic visual cues.
They absolutely do. In thyrotoxicosis, due to the high circulating levels of hormones, the facial expression can be one of excitement, tension, nervousness, and agitation.
And the wide-eyed look.
Yes, often with a wide-eyed appearance, sometimes accompanied by exophthalmos, the protrusion of the eyes. This contrasts sharply with the hypothyroid patient. Due to fluid retention and tissue changes, their face is puffy, dull, and described as mask-like, lacking normal expression.
And the mental state follows suit.
It does. The hypothyroid patient's mental state is characterized by dullness, lethargy, and general slowness, which is tragically most obvious in congenital hypothyroidism or cretinism. The difference between the excited, restless hyperthyroid patient and the dull, listless hypothyroid patient is a clinical snapshot of their underlying condition.
Let's focus on the pulse rate. Tachycardia is expected in hyperthyroidism, but the source emphasizes a specific measurement, the sleeping pulse index. Why is this so much more crucial than a simple resting pulse measured in the clinic?
This is a fundamental clinical insight. The major drawback of measuring a pulse in the clinic is the inclusion of anxiety tachycardia.
Right, the white coat effect.
Exactly. The patient's nervousness or the physical exertion of walking into the examination room can temporarily elevate the rate. The sleeping pulse rate, which is often measured by the patient or a family member at home, eliminates these confounding factors.
It's a true index of their metabolic state.
A true index. And the source provides clear grading based on this.
What are the numbers?
A sleeping pulse rate below 90 beats per minute suggests mild thyrotoxicosis. Between 90 and 110 indicates moderate to severe disease, and anything consistently above 110 points to severe thyrotoxicosis.
And the reverse for hypothyroidism, of course, bradycardia.
Right, a slow pulse.
Our final clue from the general survey is the skin clues, the extremes of heat versus cold.
This is a simple, effective test that should happen naturally as you shake the patient's hand or take their pulse. In primary thyrotoxicosis, the skin, especially the hands and palms, is characteristically moist, hot, and sweating.
A direct consequence of that hypermetabolic state.
Yes, and peripheral vasodilation trying to shed excess heat. Conversely, in myxedema, reflecting the low metabolic rate and localized edema, the skin is dry, coarse, and inelastic.
We now transition to the local examination. We start with inspection. The thyroid in its normal state is not visible, so how do we optimize our chances of seeing a subtle swelling, especially in difficult patients?
Inspection can be challenging, in obese patients or those with short, thick necks. Therefore, we use specific maneuvers. The source outlines Patilla's method as highly effective.
Okay, walk us through Patilla's method and explain why it helps.
The patient is asked to clasp their hands behind their head, resting them on the occiput, and gently push their head backward. This maneuver achieves two things. First, it extends the neck maximally. Second, And more importantly, the act of clasping and pushing tightens the anterior neck muscles and fascia, pulling the soft tissues taut.
Ah, so it creates tension.
Exactly. This increased tension facilitates better inspection and visualization of subtle thyroid enlargement or asymmetry.
Once visualized, what are we looking for in the types of swellings?
We categorize the appearance. Is the enlargement uniform involving the whole gland symmetrically? That would suggest a physiological goiter, colloid goiter, or Hashimoto's.
Or,
Or do we see isolated nodules or an irregular bumpy surface, which suggests a multinodular goiter and an important visual caution?
go on.
Sometimes the primary swelling isn't visible at all. A seemingly unrelated swelling felt laterally in the neck may be a metastatic lymph node from a tiny, hidden primary thyroid carcinoma.
Now, the physical sign that defines this entire examination, the pathognomonic movement on deglutition. We've all heard that a thyroid swelling moves when you swallow. Why anatomically is this true, and why is it so definitive?
It is the definitive physical sign because the thyroid gland is structurally fixed to the larynx via the protracheal fascia.
And the larynx moves up when you swallow.
Exactly. The larynx and trachea elevate, dragging the attached thyroid gland directly upwards. If a swelling in the lower neck moves on deglutition, it is thyroid tissue or something attached to the trachea or larynx until proven otherwise.
But the source wisely points out exceptions. How does a clinician handle these few cases that also move?
The exceptions are thyroglossal cysts, subhyoid bursitis, and prelaryngeal or pretracheal lymph nodes, but only that they are fixed to the larynx or trachea.
So how do you rule out the main confounder, the thyroglossus cyst?
You move to its own pathognomonic feature. While it moves on deglutition, it also moves upwards with protrusion of the tongue.
Ah, because of the duct.
That linkage through the remnants of the thyroglossal duct is the differentiator. And we must also observe if the thyroid's movement is limited. Limited movement is a serious red flag, suggesting fixation by inflammation or malignant infiltration.
Moving to serious complications, what visual clues suggest a retrosternal goiter, where the mass extends dangerously into the chest cavity?
Retrosternal goiter is very concerning due to the risk of major vessel compression. On simple inspection, a key visual sign is the dilatation of subcutaneous veins over the upper chest, suggesting obstructed venous return.
And clinically?
Clinically, if the lower border of the swelling cannot be determined as the patient swallows and the goiter moves up, retrosternal involvement is highly suspected.
And the absolute definitive inspection test for vascular compression is Pemberton's sign. It sounds dramatic. How is it elicited, and what is the underlying mechanism of the positive result?
It is a critical and potentially dramatic test. The patient is asked to raise both arms over their head until they touch their ears and to hold that position for about 60 seconds.
And if it's positive?
In a positive Pemberton sign, the patient will rapidly develop facial plethora, that's flushing or congestion cyanosis, and distress, sometimes leading to dizziness or syncope.
Why does just raising the arms cause this immediate congestion?
It's mechanical. The retrosternal goiter is already compressing the great veins, the jugular and subclavian veins, at the thoracic inlet. When the arms are raised, the clavicles and associated muscles shift slightly, physically narrowing that thoracic inlet even further.
I see, so it's an exacerbation.
A severe exacerbation of the external compression on the veins caused by the goiter. It immediately cuts off venous drainage from the head and neck, resulting in the visible congestion and distress. It's an urgent indication for intervention.
Inspection gave us a general view. Now, palpation is where the real diagnostic work happens. This is where we determine consistency, texture, and true size. What is the optimal starting palpation position?
The patient's neck must be slightly flexed to ensure the neck muscles, particularly the sternomastoid, are relaxed. This allows your examining fingers to reach the gland more easily.
And you can do it from behind or in front.
Right. Palpation can be done effectively either from behind the seated patient, which is often easier for confirming size in the lower border, or from the front.
Let's detail the techniques from behind. How do you ensure you cover the entire gland?
The clinician stands behind the patient, places their thumbs behind the neck, and their remaining 4 fingers gently on the anterior surface, covering each lobe in the isthmus. To better assess a specific lobe, say the left, you ask the patient to flex their neck and rotate their face slightly towards the left.
Which relaxes the sternomastoid on that side.
Correct. It allows for deeper palpation of that left lobe. And to make a nodule pop out, you ask the patient to extend the neck slightly.
And the key techniques from the front, like Leahy's method, this seems designed for isolating individual lobes for detailed scrutiny.
That's its exact purpose. Leahy's method allows for thorough, one-sided examination.
How does it work?
If you want to palpate the left lobe, you stand in front, use your right hand to push the entire thyroid gland towards the left. This pushes the left lobe out from behind the trachea and makes it prominent against the sternomastoid muscle, allowing your left hand to palpate it meticulously.
And you just reverse for the right lobe. And a simple but effective technique for subtle enlargement. Kryle's method.
Kryle's method is often used to catch those early subtle changes. You place your thumb directly on the thyroid, typically near the isthmus, and ask the patient to swallow.
So the gland moves up against your thumb.
Precisely. The act of swallowing brings the gland up against the stationary thumb, allowing you to appreciate even minor enlargement or the presence of small, early nodules that might otherwise be missed.
Once we have the gland isolated, we proceed to detailed nodule assessment. This is where consistency provides the most critical diagnostic information.
Absolutely. First, we characterize the general enlargement. We look at the surface texture. Is it smooth, which suggests primary toxic goiter, or a simple colloid goiter, or is it bosselated?
Meaning bumpy.
Irregularly bumpy and nodular, which is characteristic of a multinodular goiter.
And what defines the crucial differences in consistency?
The consistency dictates the pathology. The gland feels firm in primary toxicosis and in chronic inflammation like Hashimoto's. It is typically softer and more elastic in a simple colloid goiter.
And the red flag.
If the gland feels hard, stony, or highly variable in consistency, this is a major warning sign, suggesting either the rare fibrous renal thyroiditis or, more ominously, carcinoma.
But there's a caution here.
A key caution.
Sure.
Tense cystic swellings, which have high internal fluid pressure, or those with significant calcification, may feel deceptively firm or hard, mimicking malignancy.
We must assess mobility. We noted earlier that limited movement suggests fixation, but how exactly is this assessed during palpation?
Mobility is assessed by attempting to move the gland in both the horizontal, so side to side, and vertical planes, separate from swallowing. Benign swelling should be highly mobile.
And if it's fixed?
If the swelling is completely fixed to the deep structures, the underlying prevertebral fascia, strap muscles, or trachea, is a grave sign. This profound fixity strongly suggests an advanced malignant tumor that has infiltrated surrounding tissues.
The final key palpation technique is vital for safety, excluding retrosternal extension by checking if we can get below the gland. Describe that technique and its implications precisely.
This is a practical, crucial maneuver. You place your index finger firmly on the palpable lower border of the thyroid swelling and ask the patient to swallow. If the lower border moves up during deglutition, and you can slide your finger completely underneath the gland, meaning you can feel the end of the thyroid tissue, then retrosternal extension is extremely unlikely.
And if you can't get your finger under it?
If you cannot define the lower border, or if the finger cannot be slipped below it during swallowing, that portion of the gland likely extends downwards behind the sternum, confirming suspected retrosternal extension.
We've covered the basics. Now we move into specialized tests and the use of other senses to complete the local exam, starting with actively looking for pressure effects. This is where we test the functional impact of the mass.
Correct. We move from identifying the mass to confirming its harmful impact. Pressure on the tracheolarynx is confirmed if the patient reports stridor or dysmoa, and the classic clinical test for this is Kocher's test.
How is the tracheal Kocher's test performed?
You apply gentle compression or pressure to one lateral lobe of the thyroid. If this compression produces or exacerbates stridor or causes coughing or distress, it indicates a significantly narrowed or obstructed trachea,
Which you'd see in.
commonly seen with large, long-standing multinodular goiters or rapidly infiltrating carcinomas.
What about the pressure on the carotid sheath? That test seems highly specific for malignancy.
It is arguably the most insightful test for advanced malignancy. You have to palpate the carotid pulsation carefully.
Okay.
A benign thyroid swelling, being encapsulated, simply pushes the carotid sheath backward. You can still feel a pulsation behind the mass. The sinister finding is when a malignant thyroid growth has engulfed the sheath. In this case, the pulsation of the carotid artery is completely obliterated when you palpate the side of the mass.
And that's also called Kocher's test.
Right. Kocher's test on the carotid sheath, and its positivity indicates unresectable disease because the tumor has adhered to major vascular structures.
That is a profound finding based on simple palpation. What about the ultimate pressure effect compression of the recurrent laryngeal nerve and the less common compression of the sympathetic trunk?
Hoarseness of voice is the key symptom for recurrent laryngeal nerve involvement. And if the sympathetic trunk is affected, which runs adjacent to the carotid sheath, the patient develops Homer syndrome.
For our learner audience, what are the classic four components of Homer syndrome and what causes them?
Homer syndrome results from interruption of the sympathetic nerve pathway. The four components are 1. Enophthalmos, a slight sinking of the eyeball; 2. Pseudoptosis, a slight drooping of the upper eyelid; 3. Miosis, a contracted pupil; and 4. Anhidrosis, no sweating on that side of the face.
So that cluster points to deep neck involvement.
Yes, potentially by a high-level tumor extension.
How do we definitively determine tracheal position if deviation is suspected?
An experienced clinician can often detect deviation through careful, deep palpation, but clinical suspicion must be confirmed by imaging. An X-ray is necessary to confirm the position and, critically, to detect scabbard trachea, a severe, flattened, and narrowed tracheal shape caused by long-term extrinsic compression.
Now, a moment to reflect on assessing toxicity, because this is where the general survey and local exam results must converge.
Exactly. We have to determine if the toxic manifestation is primary, Graves, or secondary toxic nodular goiter. This distinction guides both management and prognosis.
And the deciding factor is the brunt of the attack.
That's the phrase, primary toxicosis. The brunt falls on the nervous system tremor, anxiety, excitement. Secondary toxicosis. This is superimposed on an existing enlarged gland, and the brunt falls mainly on the cardiovascular system. Irregular pulse, heart failure.
Let's talk about percussion. The source describes it as having more theoretical than practical importance. Why do we still include it?
It's included for completeness and for one specific scenario, ruling out retrosternal goiter. Percussion is performed over the manubrium sterni. If a dull note is elicited where normal resonance should be, it suggests the mass extends deeply into the chest. So, imaging is far more accurate.
And finally, auscultation, the search for the brute.
Auscultation is non-negotiable in suspected hyperthyroidism. A high flow of blood, particularly in Graves' disease, generates a systolic brute, a distinctive, humming, harsh sound heard over the goiter.
Usually near the superior poles.
Right where the vessels enter. We should also check for a pulsation or thrill during palpation that precedes or accompanies the brute.
The conclusion of the local exam is purely objective. Final measurements.
Simple, consistent measurements are essential for monitoring. Clinicians measure the circumference of the neck at the most prominent part of the swelling. This objective data tracks growth or regression, which is vital.
The general examination is complete, but we must now zoom in on the specific systemic signs of hyperthyroidism, starting with the complex and defining ocular manifestations of primary thyrotoxicosis. Why are the eyes so profoundly affected by Graves' disease?
The ocular signs arise because the same autoimmune process that attacks the thyroid can trigger inflammation, fat accumulation, and edema in the retroorbital space behind the eyeball.
Pushing the eye forward.
Pushing the eye forward, and the toxic state affects the smooth muscles around the eye. Crucially, these signs can be unilateral or bilateral.
Let's break down the mechanics. First, lid retraction. How is this different from true bulging?
Lid retraction is purely muscular. It's caused by the overactivity of Muller's muscle, which is sympathetic nerve dependent. The upper eyelid is held higher than normal, exposing the sclera above the iris. The patient develops a wide-eyed staring look, but the eyeball itself is not protruding.
Next, lid lag, famously known as von Graef's sign.
Lid lag is a delay in movement. When you ask the patient to track an object slowly downwards, the upper eyelid fails to keep pace with the descending eyeball.
It gets left behind.
It appears to lag behind, only catching up later. It reflects the abnormal tone of the eyelid muscles.
And the most severe finding, exophthalmos, the forward protrusion.
Exophthalmos is the actual pushing forward of the eyeball out of the socket. This occurs due to the buildup of retroorbital fat, edema, and cellular infiltration. When it is present, the sclera is visible not only above the iris, but sometimes below it as well.
The source lists 4 other classic other eye signs, mostly related to muscular function or the nervous stare.
Yes, there are nuances of the toxic state. There's Stellwag's sign, which is that staring look with infrequent blinking. Dalrymple's sign is simply the visible upper sclera.
And Joffrey's and Mobius's.
Joffrey's sign is the absence of forehead wrinkling when looking up. And Mobius's sign is the inability to converge the eyeballs on a near object, reflecting muscle weakness.
In late and very severe cases, the structural damage leads to ophthalmoplegia and chemosis.
Right. Ophthalmoplegia is the weakness of the eye muscles, leading to double vision or diplopia. Chemosis is a dramatic sign of severe retroorbital pressure. It is edema of the conjunctiva, giving it a thick, crinkled, gelatinous appearance.
Moving to the overall systemic impact, let's confirm the other cardinal signs of primary toxic goiter, Graves' disease, beyond the eyes.
These are the systemic manifestations of that hypermetabolic state. First, tachycardia, a constantly rapid pulse rate, confirmed by the sleeping pulse rate index. Second, tremor, an almost universally present fine tremor of the hands, best elicited when the patient extends their arms and spreads their fingers.
The nervous system involvement.
Exactly. Third, moist skin, those hot, moist palms. And fourth, the thyroid brew we just talked about.
This brings us back to the crucial distinction, secondary thyrotoxicosis. If Graves hits the nervous system, where does secondary toxicosis strike?
Secondary toxicosis is toxicity superimposed on a gland that was already diseased. A long-standing nodular goiter. The patients are typically elderly. Here, the brunt of the attack falls mainly and often exclusively on the cardiovascular system.
So we're talking auricular fibrillation, heart enlargement.
Signs of congestive cardiac failure like ankle edema and orthopnea. And the crucial diagnostic difference is that exophthalmos and tremor are usually absent or extremely mild in secondary toxicosis.
Finally, if malignancy is strongly suspected from the local examination stony, hard, fixed, irregular mass, the general survey must culminate in a thorough search for metastasis.
The search has to be systematic based on the known patterns of spread for different carcinomas.
So for follicular.
If we suspect follicular carcinoma, we must check for bony metastasis in the skull, spine, long bones, and pelvis as it spreads via the bloodstream. We also check the lungs.
And for papillary.
If we suspect papillary carcinoma, the focus is on cervical lymph nodes. Papillary carcinoma is notorious for early lymphatic spread. Meticulous palpation of the entire chain of nodes is essential.
The systematic clinical assessment provides a strong differential diagnosis. Now we transition to confirmation and precise measurement. The clinical findings dictate which special investigations we use.
The investigations are critical for confirming suspicion and guiding treatment. We categorize them into in vitro, blood chemistry, and in vivo imaging and uptake tests.
Starting with the in vitro tests, let's briefly look at the historically significant serum protein-bound iodine, PBI, and why it has been superseded.
PBI was useful, but it has severe limitations. It gives false high readings in pregnancy or after contrast media, and false low readings if the patient is taking common drugs like salicylates. It just lacks specificity.
Which brings us to direct hormone measurement, serum thyroxine, T4, and triiodothyronine, T3.
These are the direct measurements. T4 is the main circulating hormone, but T3 estimation is essential because some hyperthyroid states, particularly those with autonomous nodules, present only with an excessive rise in T3. It's called T3 thyrotoxicosis.
We also need to assess the thyroid hormone binding capacity using the T3 resin uptake ratio.
Right. This test measures how many binding sites are unoccupied on the plasma proteins. In hyperthyroidism, most sites are bound, leading to a low percentage of T3 uptake. In hypothyroidism, many sites are free, leading to a high percentage.
It's an indirect way of assessing free hormone levels.
It is.
And the test currently considered the most reliable single indicator is the free thyroxine index, FTI.
The FTI is a calculated value, usually T4 times the T3 uptake percent. It effectively corrects for changes in binding globulin concentration, so it closely correlates with the actual free T4 level available to the tissues. It's probably the best single biochemical test.
Moving higher up the axis, serum TSH.
TSH is the regulatory hormone from the pituitary. Its measurement is crucial. It is dramatically raised in primary hypothyroidism because the pituitary is screaming at a failing gland.
And in hyperthyroidism.
It's often almost undetectable because the high circulating T4 and T3 suppress pituitary output via negative feedback.
And the most complex test of the axis, the hypothalamic pituitary axis test, TRH test.
This tests the feedback loop explicitly. You inject TRH. Normally, this causes a predictable spike in TSH. In hypothyroidism, the rise is exaggerated.
But in hyperthyroidism,
the pituitary is already suppressed, so the TRH injection elicits no response. The TSH level remains depressed.
Let's transition to the in vivo tests, involving imaging and uptake. What are the current preferred radioisotopes?
99-MolBCC, or technetium, is gradually replacing iodine isotopes, mainly due to its lower energy and shorter half-life, which reduces patient exposure.
Describe the uptake tests. What does an increased uptake rate tell us, and what are the crucial caveats?
Uptake tests measure the rate of tracer taken up by the thyroid tissue. An increased rate confirms a hyperfunctioning gland, which is characteristic of hyperthyroidism. The crucial caveat is that hyperplastic non-toxic goiter caused by severe iodine deficiency can also show increased uptake, leading to a false suspicion of toxic goiter.
To specifically differentiate those, the T3 suppression test, Werner, was used, but I understand this test carries significant risk.
It does. Werner's test measures uptake before and after giving the patient T3 for 5 days. In true thyrotoxicosis, the gland is autonomous, so uptake isn't suppressed much. In a simple goiter, the T3 suppresses the pituitary and uptake drops significantly.
Why is the source so cautious about its use?
Because the test involves transiently inducing a hyperthyroid state. It is considered dangerous for elderly patients or anyone with pre-existing heart failure. The safer TRH test has largely replaced it.
Now, for the definitive structural assessment, the thyroid scan, what is the critical finding here, specifically concerning solitary nodules?
The scan provides a visual map showing hot functioning parts and cold non-functioning parts. It's essential for evaluating solitary nodules. And the most critical finding is the single non-functioning or cold nodule.
And why is the cold nodule such a huge red flag?
While most cold nodules are benign cysts or adenomas, they have a significantly higher risk of being malignant, up to 20% compared to functioning hot nodules.
So a cold nodule is an indication for surgery or FNA.
Immediate fine needle aspiration cytology, yes.
Moving to miscellaneous tests and imaging. What standard imaging techniques support the clinical diagnosis?
We use standard chest and neck radiography to check for tracheal deviation or narrowing. It's also used to screen for obvious bony metastasis. A barium swallow can be used to check for pressure on the esophagus.
How about the minimally invasive tools like FNAC and ultrasound?
Ultrasound is essential for differentiating solid masses from cystic swellings, but its value in definitive diagnosis of malignancy is limited. That's where FNAC comes in.
Fine needle aspiration cytology.
It's an excellent, quick, simple outpatient test. It provides cellular diagnosis, differentiating between thyroiditis, colloid nodules, and the various types of carcinoma. It's crucial for guiding the decision to operate.
And the future. CT and MRI.
CT and MRI are powerful tools for assessing the extent of retrosternal goiter or infiltration of surrounding structures. However, the source notes that at this time they are still considered more for preoperative planning rather than routine day-to-day diagnosis.
We've gathered all the data from history, physical exam, and investigations. Now, the final step in clinical mastery. Synthesis, fitting the findings into the established categories of thyroid pathology.
The foundation remains the same. Recognition that the swelling moves upwards on deglutition. Once confirmed as a goiter, we systematically differentiate between non-toxic, toxic, neoplastic, and inflammatory causes.
Let's start with the classification of goiter, non-toxic simple goiter.
We have 4 types here. There's diffuse parenchymatous, which is that early, uniform enlargement in young people. Then colloid goiter, which appears later, is soft and elastic.
Then the common ones.
Right, multinodular goiter, MNG. This is the common form in middle age, with that characteristic bossylated or bumpy surface. The key thing here is that secondary thyrotoxicosis occurs in about a quarter of these cases.
And the solitary nodule?
Solitary nodular goiter, or adenoma, presents as a single lump. These are dangerous because they are prone to complications, including hemorrhage, calcification, and an increased risk of harboring occult carcinoma.
Moving to the toxic goiters.
Primary toxic goiter, Graves' disease. Young women, history of stress. The gland is mildly enlarged, firm, may have a bruit, and the key systemic signs are the ocular signs, tachycardia, and tremor. The brunt is on the nervous system.
And secondary toxic goiter.
Elderly patient, pre-existing nodular goiter. The brunt falls on the cardiovascular system, heart failure, auricular fibrillation, with an absence of the characteristic Graves' eye signs or severe tremor.
The final, most critical differentiation is the neoplastic carcinomas group. What physical findings are the clinical indicators of deadly nuance?
The clinical hallmarks of malignancy are profound. Hard, stony consistency, an indistinct outline of the mass, and fixity due to infiltration. This infiltration is what causes the symptoms of dyspnoea, dysphagia, and hoarseness.
Let's look at the nuances of the 4 main types, starting with papillary carcinoma.
This is the most common and generally least aggressive type. It affects young people, is slow-growing. Its diagnostic hallmark is its propensity for early lymphatic spread. You have to check the cervical nodes.
What distinguishes follicular carcinoma?
Follicular carcinoma affects middle-aged women. Its spread pattern is completely different. It spreads early via the bloodstream. This means the clinician has to actively search for metastasis in the lungs and bones, skull, spine, pelvis.
And the nightmare scenario? Anaplastic carcinoma.
Anaplastic carcinoma is the most lethal. It is a disease of the elderly, characterized by extremely rapid growth. The mass is stony hard, irregular, painful, and profoundly fixed early on. Its high infiltrative capacity causes rapid onset of severe dyspnea and hoarseness. The prognosis is extremely poor.
Finally, medullary carcinoma.
This arises from the C cells, seen in ages 50 to 70. It presents as a firm, distinct lump. The key historical differentiator is that about one-third of patients will complain of persistent, unexplained diarrhea, and it's often associated with multiple endocrine neoplasia or MNN syndromes.
This deep dive has shown us the power of a systematic clinical method. We have moved from the subtle clues in the patient's history, asking about sleepless nights or residence in goiter belts, through the visual distinctions, like Bizzolo's method, to the definitive findings discovered during palpation.
That systematic pathway is the indispensable clinical filter. You saw how palpation can distinguish the soft, elastic colloid goiter from the ominous, stony, hard, fixed lump of an anaplastic carcinoma.
The application of tests like Kocher's test on the trachea or assessing the carotid sheath allows the clinician, using only their hands, to determine the extent of infiltration.
Long before sophisticated scanning confirms it.
Even with all the incredible advancements, the sensitive TSH tests, FNAC, specialized scans, the physical examination provides the essential context.
It really does. It identifies the life-threatening irregularity versus the benign elasticity, ensuring that resources are prioritized and the patient receives the most appropriate and sometimes urgent intervention.
Absolutely. The goal is rapid, accurate differentiation. So we leave you with one final provocative thought that encapsulates the most important clinical separation in thyroid pathology.
We noted the primary toxic goiter, Graves' disease, focuses its attack, its brunt, primarily on the nervous system, leading to excitement and tremor.
In contrast, secondary toxic goiter focuses its attack on the cardiovascular system, leading to auricular fibrillation and heart failure.
So the question is this: what is it about the specific pathophysiology and underlying autoimmune versus autonomous nature of these two conditions that causes this fundamental difference in organ-targeting nervous system versus cardiovascular system?
And why is recognizing this primary clinical impact the single most important insight for managing the initial crisis in either patient?
Something for you to mull or explore on your own as you review this clinical material.
That's a wrap on this deep dive into the clinical examination of the thyroid. Go be well informed.